Hi, everyone. I just wanted to say hi while Ranjita is getting set up. Ranjita, thank you for setting this up. Sorry for the confusion.
No, sorry. I don't know if like the timing, it must have said something different, huh? Oh, I guess I didn't know this had music on it. Got it from Ryan.
Very fancy. Okay, I'm going to say something. Thanks,
I
Ranjita.
know. Well, I can't take all the credit for that. All right, let me. Okay. All right. So today we're talking about hypertensive emergencies. Um, something where you look at something like this, where if you have somebody who's 235 over 125, you'd be worried. But there's just so much more to that than just the number. And that's why this particular thing is so interesting because you really have to do a good history and physical. And there's so much more about the patient than just this one number that really denotes how we would treat the patient. So the first question that we have with hypertensive emergency, if you see something like that as your blood pressure, would be to ask yourself if it is actually real. I mean, we all work in the emergency department, and so many people come in with blood pressures that are very high the first time that they take their vital signs. There's a lot of things that will contribute to it, right? The cuff size, how the patient is positioned. A lot of times, people are just using whatever the normal size is, but if it's a larger patient, that normal size is going to give you an artificially high cuff pressure. The other things that can be related to this is whether there are other factors, like did they recently start or stop medications, or did their diet change? Are they doing any sort of drugs? Meth is really big where I work in Fresno, but also alcohol, tobacco, and caffeine. Those things are all going to have an effect on your blood pressure. And a lot of times it's pain and anxiety, and we're seeing that from a lot of patients why their blood pressure is much higher than potentially it would be if they were at home. So when you take the blood pressure, sometimes these things are going to go down for all of those reasons that we just talked about. And in 30 to 60 minutes, maybe it'll go down because they are not as anxious, they're not in pain. If they had taken some sort of drugs or something like that, it would start to go down on its own. Obviously, we don't know that's always going to be the case, but sometimes it is going to go down like that. Oh, good. Ryan's joining too. Once again, thanks to Ryan here for also helping in giving some of the slides to work with. That's why there's so many great transitions.
Resuscitation, hypothermia, ski touring, things like that. So it's split up into two, like 8 days.
There we go. All right. So the real question that we have in the emergency department is whether there is actually an emergency and to decide what testing we're going to be doing. So that's what today's topic is. The thing with a hypertensive emergency is that it's not just enough to have the elevated blood pressure, but we also need to have signs of end organ damage. And it's our job to figure out whether it is worth testing for that end organ damage and then what to do about it once we know there is something that is damaged, right? So, what counts as elevated blood pressure? Is it always the 180 over 110? Is it always the 200 over 120? It's really not any specific cutoff. Things are written, and a lot of times it will be something like 200 over 100, but really it depends on the patient themselves. And it's really their increase from their baseline and what they normally are. So that's what we really want to see. It's much easier when we have a patient where we know what their baseline is versus somebody who we have no idea if this is their normal or not normal, right? The things we worry about for end organ damage are the brain, the heart, and the kidney, which can all be evaluated through different testing, but also we worry about the lungs, we worry about the eyes. There's basically everything else that hypertension can affect, but these are the ones that we think of and are largely emergencies in the department. So for the brain, we want to think about when we're talking to them, getting a history on, have there been differences in their vision, in their speech? Have they seen a change in their ambulation, their gait? If there's any focal deficits, and if there's any headache, and if they do have a headache, whether there's red flags from their headache. Obviously, seizures and confusion will all be things that tell you that the hypertension is affecting the brain. And a lot of times, some of these things, we're going to have to get collateral from family members or people with the patient in order to gauge whether they are off their baseline. In terms of physical exam, it'd be great if we can check for papilledema. This isn't something that at least for us all the time that we are checking for. Ultrasound sometimes makes this easier to check. You can check to see if they have some papilledema with ultrasound, but if you can, that's something that can give you a good sign. Whether they have nuchal rigidity, so you can check their neck. This is all part of our physical exam. And of course, a full neuro exam to check for all the things we even asked about on their history as well. And of course, for the heart, chest pain, dyspnea, nausea, vomiting, all the things that makes us worried about either an MI, a heart attack, or a CHF exacerbation. And on physical exams, sometimes you can see signs of this with JVD, looking at the heart and lungs. Are there crackles? Using your ultrasound to see what the squeeze looks like, and also checking pulses. And once again, checking for pedal edema. Kidneys, we were asking in our history about whether they have urinary changes. So things like hematuria and discoloration as well. And for the physical exam, it's a little bit harder to really get a physical exam from the kidney as opposed to when you're checking for the brain or for the heart. Of course, you can always still do ultrasound of the kidneys, and you can check for their urine output. But once again, these are a little bit harder than with when we were looking at, let's say, heart and lungs. So a lot of the things that we're going to be checking again to kind of recap for history is, what are the instigating factors? Do they have changes in their vision, their speech, their walk? Are they numb? Are they weak, confused, seizures? Whether they're having chest pain or trouble breathing, nausea, vomiting, swelling anywhere, or if they're having urinary changes. Of course, if they're pregnant, this is also a very important factor, because even for pregnant patients, what we'd even consider hypertensive is much lower, and we have to have a much higher suspicion for preeclampsia or eclampsia. And our physical exam, once again, we want to check their mental status and do a full neuro exam, plus look at potentially the ultrasound of the heart and their lung exam, and check their peripheral pulses and see what their urine output would be. So bringing it back to the beginning, we really want to know, is this a real blood pressure? And then is it a hypertensive emergency? And that we want to check, do they have elevated blood pressure for actually, and are they having any signs of end organ damage? And talking to them from their history and physical, is there anything that makes us worried that they actually might be having end organ damage and we need to test for it? And this can be done with a focused H&P. So in the ED, we are not expected to screen for asymptomatic blood pressure, hypertensive patients. That's true, but it's really on us then to make sure that the patient in front of us is not having symptoms and don't need any sort of testing. However, if you are concerned that there is potentially a hypertensive emergency and you're not sure based off of that history and physical, then we do need to do testing to ensure that we are not having some injury to one of those systems. And so that's where it's so important to have some of that nuanced thinking about the patient and a really thoughtful examination of our patients. So hypertension can be the problem that is causing an issue. So something like an hypertensive encephalopathy, where they are confused and they're having some of these neuro changes, or a type 2 MI or AKI, the hypertension is the thing causing a problem. And sometimes the hypertension can be secondary, where there is a problem and because of that problem, we are having hypertension. And so we have to consider all of these things when we are going through our history and physical with a patient. So we talked about this, like the hypertensive encephalopathy. This is when there is some confusion. They are having neuro deficits. They're not acting like themselves. A type 2 MI is, of course, if they're having chest pain and problems with their heart. And then AKI would be injury to their kidneys. Now, whereas on the secondary side, we have aortic dissection and basically pulmonary edema that's causing problems for them. And then intracranial bleeds through intracranial hemorrhage or a subarachnoid hemorrhage. And then you can also have an overdose. We talked about before about tox causes that can cause hypertension. And then preeclampsia in our patients that are pregnant. So once again, you want to decide what testing you're going to do based off that initial H&P. And if they're asymptomatic, you really don't need to do testing for these patients. But you can have a pretty low threshold to get a BMP in order to check their electrolytes and their creatinine. And a lot of times, I mean, once again, it'd be good to know also what you guys do in Vietnam and how good the follow-up is with your primary care doctors. But a lot of times doing a BMP and finding out about their kidney function can really help with patients who don't have good follow-up and identifying people who are having kidney injury. In order to make sure that they're not having worsening problems in the future. And that can sometimes lead to an admission where they can kind of have this solved. Ooh, more music. So in terms of once you've decided that a patient has a hypertensive emergency, the goal really is to bring back down their blood pressure about 15 to 20% in the first hour. And in 2 to 6 hours, you would ideally like them to get them down to around 160 over 100. And ideally, in a few days, it'd be normal. These are goals, but it's not always easy to necessarily do that. And we have to kind of base it off the patient themselves. But you definitely do not want to bring down your blood pressure more than 20% in that first hour, because then you could be detrimental to a patient who potentially was at a very high level for a long period of time. And when we read about 20%, like if you looked at all the reading, they talk about 15, 20%. There's sometimes a question of what are we saying 20% lower of? Is it the systolic, the diastolic? Is it the MAP? And a lot of times the guidelines are saying that it should be the systolic. Probably the MAP is potentially better. But you kind of have to go based off of what you have available to you. And we have a lot of different medications that we can use, and I'm sure there'll be other things in the future But see, here are some of the common ones that are used for lowering blood pressure in the emergency department. And of course, Di, you can let us know which ones you guys tend to use in Vietnam. Labetalol is a pretty commonly used one because it has both alpha and beta functions, and the onset's within 5 minutes and it peaks in 10 to 15 minutes. And usually people will tend to give about 10 to 20 milligrams IV to start. And you can kind of continue with a max of actually like 300 milligrams. I haven't actually given that much myself, but I think that's because I probably have used a lot more of nicardipine, which is nice because it can be a drip and you can adjust pretty quickly and has the onset within minutes and can peak within 45 minutes. Clofidipine is one that's also a bit newer, and that one as well is really adjustable and the onset's even faster than nicardipine. So I feel like that's something that a lot of places, if they have it, are tending towards. Like my previous hospital uses clofidipine more often than nicardipine. Di, do you guys use either clofidipine or nicardipine at Ho Chi Minh City?
Usually we have a nicardipine.
Nicardipine? Okay. Yeah, I think that's the more common one. I think clofidipine is still pretty new and is not too many different places, because I think even in Fresno we don't have clofidipine. So the other question that comes up is whether we would need an arterial line. And I think this is something that's kind of debatable. It's very helpful, but I don't think that it's something that we are commonly doing for all of our hypertensive patients. It would be great, but I don't think the capabilities are always there. And sometimes it's not always needed, because once you're able to bring them down, sometimes they do well. So let's see. Nitroglycerin, the dose here there's different methodologies for it, and the onset also is immediate. It can take a couple minutes, but it also has vasodilation. Sublingual, which I think a lot of times we'll start with, especially with EMS, will be like 400 micrograms, and you can give that every 3 to 5 minutes as well. You can also give it in a bolus, 0.5 to 2 milligrams. And let's see. So the nitroglycerin is also really great for heart failure. And it has been shown to really help in that sense as well. And a drip plus a 2 milligram IV every 3 minutes is pretty helpful. And this one showed like that there has been like a 3%, this 2007 annals showed that there was like a 3% rate of hypotension. I haven't actually had any problems with there being hypertension, but it is something that was seen in this studies. But it had decreased the intubations and the ICU stays. This other study from 2021 from GEM had only 25 patients, but they showed that there was a mean bolus of 872 micrograms, and there was a cumulative of 35 milligrams, and that the patients in this study had not had any hypotension. So even though people were kind of concerned about nitroglycerin having hypotension, generally it's pretty safe if you know how to dose it to not have hypotension in those patients. And you can always adjust accordingly. So you can give the loading dose, or even if you don't want to give the loading dose, you could start the drip at the 25 to 50 micrograms, and you can see that onset within 2 to 10 minutes. And the duration lasts about 1 to 30 minutes. For hydralazine, this would be 10 to 20 milligrams every 4 to 6 hours. And the onset is within 10 to 80 minutes. and the duration for this particular medication is up to 12 hours. So it's good for CAD heart failure. Oh, no, sorry, it's contraindicated for CAD and heart failure. And you can have this rebound tachycardia. So it's one of those things that is used, like sometimes they like to use in like preeclampsia, things like that. But I feel like it tends not to be the go-to when you're not too sure, especially what you're dealing with, just because the duration is so long. It's kind of better to go with something that might be a little bit of a shorter duration. So when we're thinking about hypertensive emergency, a lot of times it does take some of these other testings to decide whether this is really hypertensive emergency versus urgency. And so we have to think about how we wanting to treat patients in this time where we're deciding what it is actually that we're dealing with. And unfortunately, there's actually not too much data about this. We don't really have too many good guidelines telling us what we're supposed to be doing during that time period. Hopefully there'll be more research about it in the future. But for the time being, usually I would say to just pull down the blood pressure using some of the things that we know we can use that are short acting and aren't going to be causing any other problems. So there's all these oral medications like labetalol, nifedipine, captopril, clonidine, hydralazine. But you definitely want to avoid something that's longer onset, like the amlodipine and the carvedilol. And something like metoprolol is only going to be helping with your rate and not as much with your actual blood pressure. Also, if you're worried about a patient that, say, has done cocaine or something along those lines, then you definitely don't want to be doing something that's just a beta agonist that's going to be causing just an uninhibited alpha antagonism. So you want to be careful with those things as well. Question sometimes comes up too in these patients that are hypertensive, if I can give IV fluids. And we sometimes give fluids when patients are volume down, when they're hypotensive. So you might think, oh, should I really be giving fluids in a hypertensive patient? But a hypertensive patient could still be volume depleted. So things like, renal artery stenosis, venous constriction, renal natriuresis, these things can still cause some volume depletion. So you can give fluids when you think that the patient still needs fluids, and you can use your history and your physical and ultrasound in order to decide these things as well. So some of these other secondary causes, there are things that are better to be using. I'm sure you guys all see these patients and have your go-to for what medications you'd like to use for different types of problems once you have identified them. So something like aortic stenosis, that's something where you'd want to use your esmolol first in order to get that heart rate down before you use anything for the blood pressure, just because so many of the blood pressure medications have a reflex tachycardia. And in aortic dissection, we do not want to have that because that'll exacerbate the problem. So start with your esmolol drip in order to get your blood pressure down, your heart rate down to a level that we would like. And then you can start a blood pressure medication if the blood pressure is still too high for an aortic dissection, something like a nicardipine. For pulmonary edema, this is really where we want to be using something like nitro in order to bring that blood pressure down in order to make the patient feel better. There's no specific blood pressure goal the way that aortic dissection has blood pressure and heart rate goals, but we are trying to get the patient to feel better. And a lot of times BiPAP is going to be helping with these patients as well to get that fluid out of their lungs. And then for intracranial hemorrhage, nicardipine is a good titratable drip to be used for this patient. You'd like to keep the goal under 180, usually somewhere around 140, 160 is what our neurosurgeons tend to like. so that it's not under perfusion, but it's also not going to be too high as well. And then for your overdoses, we talked about this a little bit already, but you don't want to use you don't want to use beta blockers on these patients. So you want to use like phentolamine or benzos in order to treat the patients that might be having the overdose from drugs. And then lastly, in your pregnant patients who might have a preeclampsia, magnesium is always the start. So you want to start with your bolus, 4 to 6 milligrams, and then start a drip after that. And then if they are still having blood pressure problems after the magnesium, you can give labetalol, nicardipine, hydralazine. I feel like these patients, OB-GYN does like hydralazine. And then, of course, the ultimate thing would be to deliver the baby if they are pregnant still, because you can have preeclampsia after you give birth as well. So let's say you do labs, you have a patient where you got the history and the physical, and you're a little bit concerned that there might be something that they're saying that sounds like they could be hypertensive emergency. And there are no signs of end organ damage. So you get the labs back and everything looks okay. Then when you discharge them, you would say, hey, this is, you're not having hypertensive emergency. You can go home, follow up with your blood pressure, with your outpatient doctor. You can give discharge medications for some of these patients. A lot of times what we recommend here would be if they have no risk factors, that you can start a calcium channel blocker or an ACE inhibitor or an ARB. But if they have renal problems or they have diabetes, an ACE inhibitor would probably be best. In the US, like for our Black patients, hydrochlorothiazide is usually a good option for them, but they're considering their risk factors. And if they've had previous like MI, a beta blocker could be good. But you still do need to do labs for these kind of patients. You can't just start a medication without having had the labs. If you have a patient that's, say, asymptomatic that you're seeing, I wouldn't start a medication without doing the labs and making sure that it's okay for them to start them. And, you have to be careful about bringing down the blood pressure too much in someone who's, say, elderly, and because then you can not perfuse their organs. So you have to be kind of thoughtful about the patients that you're going to start medications on. And you should ensure that they're going to have follow-up within the next 7 days if you are going to start them. I have started medications on patients, definitely, who've come to the ER who end up not having hypertensive emergency, because a lot of times, even at least here in the US, if a patient comes with high blood pressure to their primary care doctor, they might just send them to the ER, even if they're having no symptoms. So sometimes it is important for us to start things from the ER if that's the case. So you definitely want to only bring down the blood pressure if you are having a hypertensive emergency. You don't need to bring down the blood pressure if the patient is just having high blood pressure asymptomatically. And you want to start with labetalol if you're trying to get your nicardipine drip, but then you might want to move to nicardipine because that is an easy on and off medication. And then you want to make sure that you are targeting the disease that you think the patient has, or the patient has in specific, right? So what you are going to do for a patient with pulmonary edema is going to be very different from a patient that you think has preeclampsia. And you should be able to tell what your oral medications are from each other. So you're not using something like, let's say, hydralazine that may last 12 hours for a patient that you don't want to have a long-lasting medication. So a lot of the main points here, the first thing is to check whether this blood pressure is real or not real, because lots of people are going to have a hypertensive blood pressure from triage, and they may not be using the right cuff. They may be anxious. They may be in pain. And these are not real blood pressures that we should be taking into account, at least for the disease process. And then are they having a hypertensive emergency? And that's going to be, are they actually hypertensive? But then also, are they having end organ damage, or are you concerned that they are based off of their history and physical? And then you want to have focused testing based off of that initial history and physical. It's not every patient that has high blood pressure that we're going to be getting a head CT, EKG, and labs and everything on. So this is where we really have to use our own medical knowledge and thoughtfulness to decide what we are going to do for this patient, and not just follow a set algorithm. And we have to make sure that even if they are having a hypertensive emergency, that we're not dropping their pressure more than 20%. We're really just aiming for more of a 15 to 20% in that first hour. And use the drug that would be specific to that specific disease that we think is happening for our patients. Do we have any initial questions before we go for a case? Right, I'm going to take that as a no. All right. All right, so for this case, we have a 62-year-old man with a headache. All right, and the vital signs we get from triage, heart rate is 92, blood pressure is 220 over 130, and the respiratory rate is 14, and he's satting 100% on room air, and his temperature is normal, 37.1 degrees Celsius. And when you look at him, this patient, he's alert but uncomfortable. He has his hands on his head, his eyes are closed. So nothing that really stands out too much at this point. So you do your ABCs, where we should be starting with all of our patients. And he's talking normally, and his breathing is clear. Has normal work of breathing, and his circulation, he's got warm skin and 2+ distal pulses. So what do you want to do now? Is there anything you guys want to do now? Do you want to jump just straight to the history? Any thoughts?
Okay. The patient has the hypertension. The ABC is okay. Maybe we will repair the IV if we need to give the patient medication by IV, and then we begin with the history and physical to decide emergency hypertension or not.
Yeah, that sounds great. And can you tell me how to pronounce your name? Is it Hotu or
Two, yes.
Hotu?
Hello, Ryan.
Okay.
So happy
Yeah.
to see you today.
Yeah, I know. Hey, happy to see you too. I remember you answered a bunch of my questions last week too, so appreciate it. And you're right on. Yeah, like this is somebody he's got pretty high blood pressure, so starting an IV, because we might need to be giving him some medications, is great. Just like we were talking during the lecture, is that blood pressure real? Because you said it yourself, the ABCs look okay. So it would be good to know if this is actually a real blood pressure. So getting a repeat, making sure we're using the right kind of cuff, having the patient be on the monitor, and then having potentially considering whether we should need an EKG or glucose. I would say a neuro exam would be good too for these kinds of patients, like a quick neuro exam to make sure that it's not somebody that we would need to get a stat head CT on. Sometimes our stroke patients are coming in with these high blood pressures. So someone I would probably come and just make sure that it's not somebody that we need to go and get that stat head CT on. But for the most part, we're going to be going and getting that history and physical, just like you were mentioning, because that's going to give us the idea of what exactly our testing is going to be, since it's so important for this particular disease process. So what is some of the stuff that you think is important to gather from the history of this patient that has a headache? Well,
Well, for the chest,
I will want to ask him if this headache is the worst headache he ever had, and if he has any kind of trauma right before the headache.
yeah, exactly. I mean, that I know it's like I'm sure you guys would know just from talking to the patient, but exactly. Is this something where it's the worst headache of their life? Did they have trauma? Because that is a totally different situation. Um, when was the onset? What's the quality of it? Does it radiate anywhere? Does anything seem to make it better or worse? I'd want to know if there were some associated symptoms. And then besides the trauma, like, was there what medications is this patient taking? Anything new? Are there any drug use? Anything new? And then of course the regular things like their medical and surgical history. So we talked to this patient, and we know it's a 62-year-old. He has a history of hypertension, had a headache that started about 8 hours prior to arrival and has become more severe slowly. He was sitting at his desk when it happened, and it's just sort of worsened during the course of the evening. It's a global headache, and it's constant, throbbing, severe. And since the onset, he has felt a mild nausea, but not had any vomiting, and has not had any headaches like this before. No neck pain, no chest pain, no shortness of breath. And he does take metoprolol and hydrochlorothiazide, but he ran out some time ago, maybe a couple months ago, and hasn't refilled it. And then he said he doesn't smoke or use any drugs. And then for the physical exam, the patient, when we saw him already, he was looking non-toxic, but he's telling you that he's telling you the place and where who he is, but he gets the year wrong. Otherwise, the rest of the exam is normal, and this is one of the ones where I've like highlighted that some of the important things that I would probably look for in a patient like him would be that neck exam and checking the vision and whether he has normal eye movements. The lung exam and heart exam would be important in somebody like this, so because he could definitely be having both something with his head, but also with his heart or kidneys and lungs as well, right? And then a very thorough neuro exam. So even if you did that quick neuro exam right at triage with a patient with this blood pressure, but you'd want to do a full neuro exam now. And of course, like always, a skin exam as well. So what is in your differential? Like, what are some of the things that you are worried about in this patient that you think you might want to consider or test for? Maybe we can go by.
I think about the other cause of the headache, for example, migraine. tension headache.
Yeah, migraine, tension headache, those would be very likely. What are some of the bad things that we'd be also concerned about?
We will have to consider if he has a stroke or not. Maybe intracerebral hemorrhage.
Yeah, I think so. Of course, it's someone presenting with a headache. A lot likelihood would be that there would be something that had to do with the system of the head, which is like a tension headache. I think lots of people who have hypertension have headaches. And they're just having headaches from having high blood pressure. They could be having a migraine along with that tension headache. They could have cluster headaches. Sometimes just the simple sinusitis infection that they have can cause these sort of headache as well. Something that was more rare would be like a giant cell arteritis, although this patient didn't talk about having temple pain or have any vision changes, which would be something that would be very emergent. Subarachnoid hemorrhage or intracranial hemorrhage, obviously that would be something that we'd be concerned about, which would be why I was talking about doing that neuro exam up front if you're really concerned there is a head bleed to get quick imaging. Meningitis, encephalitis for this patient seems less likely since they don't have a fever and didn't have neck stiffness and weren't complaining of those things, but still something to consider. And then things from different other systems, if we're thinking about the heart, they could be having ACS. I know they didn't talk about chest pain, but it's still possible. Aortic dissection, also a very rare and really hard thing to diagnose because the symptoms can be really vague, but that's possible. CHF, we didn't hear any crackles in the lungs, but it's something that we want to listen to and make sure that we're ruling out. A stroke, the neuro exam was normal, so that's also really reassuring, except for the fact that he was confused. Hypertensive encephalopathy, definitely something that would be higher on the differential, given that he was a bit confused and is hypertensive. And then something like a mass possible once again, although the time course was really acute, so maybe less likely. And then something like press can cause some of these symptoms as well, so something else to keep in mind as well. Is there anything else anyone thought of? All right. Yeah, I think that's a lot of the things that we'd probably be looking at. AKI, that's missing from this list as well, kind of considering our kidney would be something else. And then this patient didn't talk about their eyes, but maybe like a glaucoma or something like that. You could be if they were having pain behind their eyes or something like that, but probably not likely in this patient with the normal eye exam as well. What labs and imaging would you guys want to order on this patient?
The heart enzyme, kidney function. Maybe we need to do the head CT scan.
Yeah, I agree with you. I think it's so tough because a lot of you can't get a head CT, or it's very difficult to get a head CT on every single hypertensive patient that has a vague headache. Because I think a lot of patients come in with a vague headache, but this particular patient had a very, very high blood pressure and was alert and oriented only times 2. And from what we at least know, that might not be their baseline. So it makes a lot of sense that in this particular patient that we'd want to get a CT of their head. So I agree. I'd want to get the CBC, get a BMP to look at their kidney function. We can look at their liver function as well. a UA will also give us some information about their kidneys, and then possibly a trope and BNP to look at their heart. He didn't have chest pain, but we can see whether that is something that's contributing, along with an EKG, a chest X-ray will also give us some look at their lungs and heart, and then of course the CT brain. And you can consider a CTA if you thought there were some red flags for potentially having an aneurysm or a subarachnoid, something like that, where a CTA would be helpful. But a CT brain, yeah, would do. So this is the chest X-ray. Is there anything particular on it? So you want to look at this and tell me what they think about it?
No pulmonary enema, but very difficult to see the dissection with the X-ray.
Yeah, it's not always the best, but yeah, nothing too obvious on it. There's no obvious pulmonary edema, and the heart looks like it's a decently normal size. The mediastinum doesn't look incredibly enlarged. It's nothing uh too impressive. And then we have our labs as well. Any thoughts on the labs? Anything that stands out to you? Yeah, it's most of it looks like when we go through it, sodium, potassium are okay, but the creatinine here is 2.5. This would be something where I would want to see a previous lab result, kind of like we talked about last week, being able to see a previous, say, EKG or previous lab results. Those things are very useful to know whether this might be a new or old finding, but you can definitely see that there's some kidney injury, considering that the urinalysis also has 3+ proteins. Other than that, it doesn't look like he has signs of inflammation with the white blood cell count. Doesn't seem like he's bleeding anywhere with the hemoglobin. And then there's nothing too impressive in terms of having problems with liver function, but does look like he is having an AKI or some sort of kidney injury from the labs. It's the main thing I see here. And then we have the CT head. We just have the one image. So anybody want to tell me what they think about the CT head? So write in the chat. Like, you think it's normal or anything concerning there? I do know it's like a blurry one image, but
From this image alone, I think it looks quite normal to me.
yeah, wasn't trying to trick you. So looks pretty normal. I mean, things we'd be concerned about in a patient like this would be if they had something like a subarachnoid. They didn't say they had any history of trauma, so but it doesn't look like we see anything like that, and there is no shift. So I don't see anything that would make me think that there is something kind of like a bleed, or at least not a old stroke that was done in the last 24 hours. But so what would you say that this patient potentially has, and what are you thinking about maybe what their dispo is now that we have some of that initial information?
Can I ask about his kidney function before? Because I not
Yeah.
you told that his creatinine is high, but we don't know his kidney function before,
Right.
and we see the trace of the blood and protein in his urine analysis. Is maybe not the acute kidney injury, maybe the chronic. I'm not sure.
Yeah, I agree. It's definitely hard to know if we didn't have a previous labs, whether this is something new or not new. Obviously, it's good that his potassium is not elevated, but given that this is a patient that I know it's so hard to remember the beginning of the case, but he was on all of these other medications that he's not taking anymore, and he has this pretty elevated creatinine. It's somebody that I would say we have to just assume at least that it's probably an acute kidney injury, or at least something that needs some treatment right now, or it's going to get worse. So it would be someone that I would potentially want to treat. And then in addition, because we have to take everything into account, this is a patient that also was a little bit confused, where he didn't know what the year was, even though he was oriented to place. So considering that he has a really high blood pressure, and he is a bit confused, and he has that kidney injury altogether, it would be something where I would think that he would need. I would probably want to keep him here and like admit him to the hospital because he has all those things. Potentially, if he had just had the kidney injury, maybe that would be something where if we're not sure if it's acute or chronic, we could maybe give some fluids, recheck, and see how he has responded, and then seeing if he could have gotten follow up with a doctor, and that might be okay. But given the whole package of having the other symptoms of a hypertensive encephalopathy, and he has been off the medications and he has a kidney injury, altogether makes it more of a concerning picture that would need admission. Does that?
Okay.
Yeah.
Okay, I agree. Maybe we need to give him the IV medication for reduce the blood pressure, and then we check.
Yeah, totally. Exactly. But yes, I agree with you. Like if it was just acute kidney injury, then, there are potentially more factors there's more ways to kind of treat it than maybe just a straight admission. And we could potentially do just giving some fluids if he had no other concerning factors, and seeing what his outpatient um, uh, management was like, if we could get a hold of his doctor. But yeah, for this particular patient, I would give the medications just like you were saying, an IV medication in order to treat this sort of hypertensive encephalopathy and the kidney injury. We'd have to assume it's acute. Sometimes also in our job too is, even if, is to make sure that we are treating what could be that worst thing that could be happening. So I think you kind of had stated, yeah, I want to start the IV medications. Did you have any pick for what medication you might want to start?
Um, this patient has hypertension emergency, so I probably would want to start an IV medication, maybe nicardipine.
Yeah, I think that sounds pretty great. That's probably what I would pick too. Nicardipine is great because it is a drip. Just like you said, we can titrate it pretty easily. We can see how he's doing, especially since it's like an encephalopathy with him. We can see whether he is improving on that nicardipine drip, and we can really make sure that we're not dropping him more than that 15%, which is what we kind of want in the first hour. And then we want to do pain control, if he's having pain, maybe some fluids because of his AKI. And then if he's feeling nauseous, we could give some Zofran or something else that's for nausea. And generally, we would want to avoid some NSAIDs in this patient, especially when he has an AKI right now. So, agreed. And then I was asking the blood pressure goals, but I already said it already. But for him, so I guess I gave that away already, but it would be around like a 15% reduction of the MAC would be the ideal, what we're aiming for in that first hour. So for him, from his initial blood pressure, that would be kind of getting him down to a MAP of 135 and then kind of taking it a little bit slower from there so that we are not lowering it so much, because then we'll be causing more problems. Great. Okay. Did you guys have questions about that one? Because yeah, it's like so 10. I don't think, once again, we probably don't have time for the next case. But next week we're going to do a few cases, so we'll get more time. Yeah, I think
I have one question about the judgment. In terms of this patient, he has, but he also has some red flags like confusion. Um, so you decide that he may need some blood tests. So when we approach other patient, like with a very slight symptom, like a slight headache or uh, a slight discomfort with high blood pressure, when will you want to do blood test, or you just do with every patient?
yeah, no, it's a great question, and I think that's why this particular thing is so interesting, and it's really important. This is where our skills as an emergency medicine doctor comes into play, because I think a lot of patients that have high blood pressure will tell you they have a vague headache. And so I I wouldn't do it on every single patient. I think it'll depend on their their story. So, are they giving you a story that sounds like, is their headache a sudden onset headache while while they're doing some sort of physical activity? Because that's a really concerning for subarachnoid. Is their story otherwise just sounding vague? Are they not able to localize it? Do they have a history of being compliant with their medications and this is abnormal for them? Like a patient who is telling you that I take my medications every day and is able to, in the chart, you see that their blood pressure was normal last week or 2 weeks ago. That is much more concerning, right? Than the patient, like in this, than a patient who says that that they've never been taking medications. You want to take into account some of those things that they are talking about, and then their physical exam. I think if there's anything that's a red flag on their physical exam, I probably would be doing labs. So I don't know if that really answers it, but it's once again kind of what we were talking about before, where it's like you're taking into account all of their history of their present illness and their past medical history, and you're taking into account what their physical exam looks like. Also, what their risk factors are. If they're somebody who has a lot of risk factors, and whether they have anything on findings on their physical exam, I probably would do testing. Like we said, there's probably a low threshold to do basic metabolic panel, and then a bit of a higher threshold to do head imaging or an EKG. But yeah, in this particular patient, just the fact that he had symptoms on his physical exam and in his history would have been a concerning red flag to do some blood work on them. I also, yeah, once again, also if there's somebody who has a primary care doctor or not, things like that play into this as well.
it's a very useful answer. Thank you very much.
Thank you. Thank you. Trying to talk slower today, so hopefully it was better. All right. Well, next week we'll try to do a couple cases. So thanks again to everybody who participated. It'll be a few cases in a row. So get ready next week to answer some questions and think about your diagnoses. Thanks, everyone.
Thank you. Bye bye. See you next week.
See you next week.